thank you all for joining today. So just a caveat, I'm not a policymaker. I work with many, but actually I probably am a banker. That's the first thing I learned joining the bank from academia, is that the World Bank is a bank. So we provide loans to governments in low middle income countries, sort of with the goal of supporting development processes, and I particularly then in the health sector. But this notion of the bank being a bank is not unimportant, because it drives a lot the way we work and sort of the incentives that we face as teams working on these loans. So I changed the title a little bit. Rather than lessons from the field, I changed it into my questions from the field. So the questions that I sort of tend to see in a lot of the work that we do, and the extent to which these are sometimes aligned, but also often sort of a bit misaligned to what I see coming out of the academic world. So the presentation is not super structured. It's really more of a of a story that I'd like to tell about some of the topics that we're currently working on a lot in the health practice in the bank, and again, sort of the way we've used the evidence that's there, but also the questions for which we don't necessarily have evidence at this point. It's broadly structured across two dimensions. The first is on how do we get the supply side to deliver on quality services for the most vulnerable, so the supply side challenges of universal health coverage. And the second is how to ensure then demand of that population for these services. So those are the two pillars. And on the first one, I'd want to start with some experiences on the performance-based financing work that we've been doing quite a lot of in the bank, often a lot in collaboration with academics. I'm not very sure sort of how much everyone is familiar with these topics in the audience, so I'll give a brief introduction, but please sort of don't hesitate to signal through the chat to any of the organizers if things are really not clear. Then I'll take a step back. So I guess the most sort of straightforward answer, how to get the supply side to deliver services for many economists at some point was, well, we pay it in relation to performance. And that idea became very popular almost 2 decades ago now with many donors. It was driven by a very sort of a recognition that there was no increase in many of the sustainable, the Millennium Development Indicators they were at that time, but very little increase in service coverage and health outcomes. And there was some early evidence coming from performance-based financing schemes, a randomized controlled trial actually, in Rwanda, that showed that paying healthcare providers in relation to performance would have dramatic impact beyond just the resources, but really the incentives. So that triggered quite an important group of donors to come together. The UK was one of them actually, to come together and pool resources into the Health Results Innovation Trust Fund that was set up as an MDTF, a multi-donor trust fund in the bank. And it supported these PBF projects in 29 countries. It provided funding for the implementation of these PBF schemes, but also for a very rigorous impact evaluation agenda, heavily based off randomized controlled trials. To give you a sense and to not make it too theoretical, I just want to use an example of Nigeria, because the schemes were quite alike and they resemble each other a lot. So in Nigeria, for example, what happened is that PBF, performance-based financing, was implemented in a randomly selected group of districts. PBF meant that healthcare providers, mostly sort of primary healthcare centers, were paid in relation for quantity and quality indicators. They were supervised in terms of functioning, but also, of course, verified to the extent that they've reached these indicators, and they were given autonomy to use that budget as they saw fit, with some minimal regulation. So quite a dramatic shift from the way these services were being financed through the government system. These were compared against the control group of districts where nothing happened, but also compared to a group of districts in which direct facility financing was being implemented. Direct facility financing very much resembles the performance-based financing, with the difference that their facilities were just given a lump sum budget equivalent to what was given to the PBF districts, but not in relation to these quantity and quality indicators. right? So fairly sort of straightforward idea. This was replicated in over 20 countries, mostly through RCT type of designs. And what we found in Nigeria, but again, it's fairly representative. If we look at two outcomes, for example, the children fully vaccinated and the proportion of births in facilities, you see here 4 groups. The project group is the PBF plus the DFF, so the entire bank project, then stratified PBF DFF, and then the control group. The grayish one is the baseline, and the black one is the end line. Now, if you look, for example, at the proportion of births in any facility, you look at the PBF arm, you see that institutional deliveries went up from around 50% to 65, a 15 percentage point increase compared to a control in which not much happened. So that's big, yeah, because you have to imagine Nigeria institutional deliveries, that was flat for a very long time. So 15 percentage points is really massive. If you look at the DFF effect there, just roughly, it's also significant, a bit smaller than the PBF arm. But if you look at the vaccinate variable, the upper graph, you see that it's reversed. For example, you see there the DFF arm had a bigger impact than the PBF arm. Now, on the whole, because this is a lot of evidence that was produced, but on the whole, we tend to see these results being reproduced in many of these RCTs. Of course, the results are country specific, they always are, and the schemes vary a little bit, but very rarely have we seen this massive sort of implementation of schemes that are so alike with an RCT evaluating them. We see that the PBF and the DFF arms always outperform the control group, the business as usual. But we also tend to see on the whole that the PBF and the DFF are not very different. Their impact is quite similar, implying that this incentive effect that we initially thought was so important really doesn't turn out to be the main driver. What seems to be really important is what these two schemes have in common. The fact that flexible resources were given to facilities, they had autonomy to do with these resources what they thought was the most appropriate, and they were supervised and were held accountable in some way or another to results. If you think back at that, it's not sort of, it's of course not too unsurprisingly that we find this. We're working in very poor countries, so most of these schemes were implemented in low-income countries in sub-Saharan Africa, where the resource constraints are very vast. You have salaries that are paid often too low, too late, very little operational budget, and very little autonomy at the facility level. So in retrospect, you could ask yourself, yes, we could have perhaps foreseen that the incentives were not really the problem. It was the mere lack of financing that limited service delivery, and it's that really that was alleviated through these projects. Another result is that we saw these schemes leading to improvements in structural quality. Structural quality meaning these indicators captured by the checklist. Does a facility have a clean waiting room, a this, a that, and that? So those indicators that were actually paid out against also did improve. But we didn't see that translate really into clinical quality improvements and health outcomes. So again, it's sort of question of has this entire PBF experiment, were we not over-incentivizing? Were we using a fairly expensive, because you have to imagine if you do PBF, you need to go and verify all these results and then have them counter-verified by an external agency. So the PBF arm was much more expensive, of course, than the DFF arm to implement. So weren't we rolling out something very expensive, very transaction heavy, in a situation where really the big constraint was just availability of resources? So that's an important lesson learned, and I think in some way also some things we could have perhaps had foreseen. Finally, a big issue with all of these schemes that were implemented across many countries in sub-Saharan Africa is the sustainability concerns. Very few of these schemes have been taken to scale within a government budget. And one very obvious reason is the fact that we're working in low-income countries with limited budgets. So I just took one example here of Senegal, where I was based until recently. Senegal total health expenditure around $60 per capita. 15 of those comes from the government. The majority of that 15 is stuck in salaries, so the government has no flexibility with those. And then you have to imagine that the PBF schemes that we rolled out in many countries costed around, I would say, $3 per capita. So that's huge, right? That's a big, big proportion of the government budget that we in this sense as the bank were injecting in these systems. So obviously there's the question of financial sustainability. How can low-income countries find this type of additional resources given the macro-fiscal constraints that they are in? But beyond that, and I find it more interesting, something I never thought about when I was in academia, actually working on the evaluations of these schemes, is the technical feasibility. So if you think at what these schemes were doing, these PBF projects, versus how a government system is set up and how governments are actually disbursing their resources, the two are really almost orthogonal to each other, right? In many low-income countries, even middle-income countries, healthcare facilities, especially at the lower level, they're not spending units, they're not in a short-term accounts, they don't have bank accounts, they're not allowed to receive public money. They are very dependent on input-based financing through very rigid budget lines. The government sort of allocates money to these budget lines in an ex-ante approach, not exposed in relation to results or outputs. Verification is done through an internal auditor. Very rarely that happens at the level of facility through external agencies. So the way in which these schemes were set up very much contradicted the way a government system works. And that's not to say that the government system shouldn't change and we shouldn't push for change. True, but because of the big divide between these two design aspects, these PBF projects, even when the RCTs showed big results, showed that they really could increase service coverage, and even in situations where countries did experience enough economic growth to free up additional resources, they couldn't be taken to scale because some of the reforms that are needed to address these public financial management rigidities, they take years, right? They require legal changes. They take years to implement. So something that I have really learned from this entire experience is that when we pilot something and rigorously evaluate it, it needs to, one, be well financially an option for these countries to take on with their own resources in the sort of mid to near future. And second is the pilot needs to be technically feasible within the reality of what the system can handle. I think that were two aspects that were very much underappreciated at the launch of this experience that has limited the impact of these schemes afterwards. Now, I do want to say, because I don't want to make this sound as a very negative experience overall, I think this entire PBF portfolio has changed the narrative on health financing in quite a few countries. It has put the question of how to bring more results focus or output-based payments in the health system, especially at the primary care level, on the agenda. So I think that's very much a contribution. But the question that we have now is how do you do that? How can you practically move to more output-based financing within these rigid and quite archaic sometimes government systems? What are feasible ways to do this? This is sort of reinforced now because with the COVID pandemic, governments upped a lot of health spending and overall spending, but a lot through temporary measures. And colleagues in the bank have been doing this analysis on a regular basis to look at projections, what's likely going to happen to public spending and therefore health spending in a large set of countries. And the picture is pretty bleak. Like in the majority of countries that we work in with the World Bank, government spending is projected to remain lower than before COVID-19. And then with a lot of other macroeconomic shocks that are currently happening, the situation is only getting worse. So there's very few countries where health spending can actually increase in the next few years. So we're very much stuck with the narrative of how do we create efficiency gains? How do we make and how do we support governments in making better use of the resources that they have? A big focus within that efficiency narrative, and this got big push when the Lancet Commission on Financing Primary Care published its report, has been this focus on better financing of primary care. In low and low middle income countries, I think there's sort of recognition that the the single best buy is to invest in primary care and in the lower levels of the health system, because there is where you manage diseases in the most cost-efficient way, and you can do early detection and prevention. But these are also, this is the layer of the system in most low-income countries that is financed the most unstrategically. Remember what I just explained about Senegal and the PBF countries? These facilities do not get a budget. They're subject to rigid budget lines. They get in-kind staff and supplies, often very late. So very weak purchasing at the primary care level. And this Lancet Commission heavily pushed for this idea of moving away from that input-based financing to something that is more capitation-based. Now, of course, when that when that result came out, it triggered a lot of discussion in many countries around how do we move to capitation. I thought that was really interesting because to me, it was almost the same message as what we learned from this entire PBF experience, right? That yes, facilities should have a budget, probably a fixed budget with some fee-for-service incentives on the side on top to incentivize preventive services. Very much the same idea as a capitation-based system. And I was getting a bit scared that we were going to repeat that PBF experience, that we were going to do RCTs now of capitation versus something else. While we knew already from that PBF experience, like the difficulty is getting resources to arrive at the front lines in these countries, alleviating the public financial barriers to having them being able to open a bank account and receive resources. So again, the question is very much on the how rather than exactly what type of instrument or what type of name we call it. And again, it's very important to recognize that capitation, as put forward by the Lancet Commission, in a low-income setting, basically means a block grant, right? If you don't have a lot of competition between providers, if you don't have solid health management information systems to really, track where people use what, then it boils down to district level block grants. So this question of how do you implement this, how do you get resources to arrive at the front lines is very core to what we are struggling with in many of the countries that I'm currently working in. And this is true in Africa, but also as I've moved now to the Middle East and North Africa, same problem. Now, okay, imagining we could get more resources to the front lines like we did through the PBF schemes. Remember, a lot of these schemes didn't really result in improved health outcomes, which makes you wonder what's the impact of all of this? Is it just doing more of something that isn't worth much? And I guess in some countries, that's actually the case. We see now that in low and middle income countries, mothers and children receive less than half of the recommended clinical actions in a typical preventive or curative visit. So that's huge, right? There's a lot of money being wasted at services that are not of sufficient quality to have a health impact. Just on this slide, pick one example, Central African Republic. If you look at the proportion of women that gave birth who had at least one antenatal visit, that's the coverage on the x-axis. You see that's around CER, it's around 70%, I think, close to 80% of women would have at least one antenatal visit. But if you then calculate of these, how many actually had 4 visits, one with a skilled provider that took their blood pressure, that took a blood and urine sample, those are all variables you can get from the DHS data. You see that effective coverage reduces to, 20%. So the actual effective quality coverage is much, much, much lower than the crude coverage than what we're measuring. And that's probably a big reason why a lot of these financial incentive schemes are not delivering the health outcomes. And big question we're struggling with at the moment is, well, are financial incentives even an appropriate measures to improve quality? What are other, again, practical and feasible measures through which you can improve quality of care in these countries? Another Lancet Commission that looked at this notion of high quality health systems triggered a lot of debate in the bank. It was led by Margaret Crook, and she very much reinforced this notion that facilities typically do better, like they provide better quality of something they do a lot of. Quality tends to correlate with volume, and irrespective of volume, hospitals tend to provide better quality of especially maternal and childcare as compared to these primary health clinics, especially in relation to deliveries. When things need to happen quickly, you have limited time. So it led to this sort of recommendation that delivery should happen in or very near to a hospital, not at primary care clinics. So this entire focus of skilled birth attendants that we had in a lot of our projects shifted to near or in hospital deliveries. And sort of, again, that's an interesting concept backed up by evidence coming from countries, but you also see the countries on these slides. Those are not the most constrained in terms of supply side. This is not necessarily feasible in many countries. One way of sort of trying to filter, okay, how do you prioritize the volume of births that have to be moved from primary care settings to hospital settings, is to do on the basis of risk, assessing high pregnancy risks and make sure that they are transported in time, referred in time to a hospital. So a colleague of mine, Ajay Tandon, and other colleagues looked at data from the National Family Health Survey in India, trying to see indeed the extent to which you could predict high and low risk deliveries. And interestingly, what came out of this analysis is you can't. You can't. I think they find that almost half of the neonatal deaths happen among low risk women and the other half high risk. So this ex ante prediction of risk doesn't really correlate with the mortality risk. So sort of gets back at this recommendation that all pregnancies, all births need to happen in or near a hospital. So important questions that we're struggling now with in the bank, in the design of our project is, so how do you do that? What proportion is feasible, right? Because of course you have limited supply side. You cannot bring you cannot have people travel for hours. You can't build hospitals. Well, I guess you could, but you couldn't staff them up or have operational costs for the future to have them kept operational. So we're currently looking into sort of what are feasible ways and financial incentives, ways of steering both women at the demand side and providers on the supply side to having more and more births shifts from the primary care clinics to hospitals through some examples that are on this slide. I think you're all familiar with those, basically provider payment reforms, and on the demand side as well. But again, something I really want to stress is on these supply side incentives is the problem for us very much working on this with policymakers is feasibility, right? For example, capitation with fee-for-service top-up for delivery referrals. That sounds technically very straightforward, but think back of this PBF experience, this is very hard to do. Again, facilities, they don't receive money. So how are you going to incentivize them, right? How do you get that money to actually trickle down to the level of the providers? A lot of the health management information systems are paper-based. So how even do you measure timely referrals? So a lot of the work is trying to think through these high-level sort of technical recommendations into practical solutions on the ground in systems that are rigid, weak public financial management, and weak health management information systems. Just watching that. Yeah. And I spoke a lot about maternal and childcare in Africa because it's sort of a lot of the bulk of the work that I was doing up to recently. But interestingly, now moving to the Middle East, North Africa region, you see very similar debates in relation to NCD management. The health systems in sort of this middle income region of the world suffer from too hospital-centric systems. Actually, too many things happen at the hospital level here meaning I'm currently based in Morocco, and too few happen at the primary care level. There's very low rates of screening for hypertension, diabetes, very high rates of hospital services to address the sort of bad health outcomes from these diseases. So here again, the question in this region is how do we shift these health systems to pay more attention to primary care and have more active and output-based financing for primary care levels? Again, here as well, in a situation where these facilities do not receive money and are not linked to the health management information system that only works up to the hospital level. So again, a lot of the advice sort of then, going to the scientific literature, a lot of the suggestions on bundled payment, bonus payments, performance incentives, become practically very complicated in this context where resources don't easily arrive at that level. So again, it's the same, actually very similar agenda in the Middle East region as compared to Sub-Saharan Africa. So that's some reflections on that first topic on how you incentivize the supply side to deliver services. I guess the common denominator was a lot about how you shift the focus on the lower levels of the system. The second part, I wanted to just share some reflections on how to incentivize the demand side. How do you make sure that people sort of have demand for the services that are most cost effective? We know, and we saw that in the previous slide, in many countries, access is really not a big issue anymore. It's access to quality services that are also affordable. And in most surveys, if you would ask people why they are not accessing services, affordability is a key issue. I know that's self-reported, but still it tells you something that keeps on coming up. We see that despite a lot of financing schemes in many countries, pooled financing schemes, out-of-pocket payments remain incredibly high or often only increasing. The recent Universal Health Coverage Monitoring Report that is released by the WHO and the bank every year shows worsening trends on financial protection for many countries. So there's really a problem that in the majority of countries, the bulk of financing comes from out-of-pocket payments, which is hugely inefficient and inequitable. The problem with this sort of on our side is that the ways to measure financial protection are very dependent on household surveys, which come very late and very rare. So we don't really have data to discuss with policymakers what's happening and whether certain interventions are actually leading to improvements because of this dependency on survey data. I think COVID triggered quite a few innovations in the field of data collection, a lot of phone-based, rapid and high-frequency phone-based surveys. We started some of those as well within the bank together with the poverty teams. Initially, this was driven by this need to get a sense of what was happening in countries under the COVID pandemic in terms of access to care. But interestingly, from this data, this is this high frequency phone-based survey where we were calling households, I think it was monthly even. Interestingly, what we saw in low income countries, the biggest burden to using facilities was financial. It was before COVID, it was during COVID, and after COVID. Like the cost of services is the biggest barrier to using services in many countries. And recognizing this, and in response to that, many of these countries in the world, but especially also now in quite low-income countries, is to roll out social health insurance type of schemes. So the motivation is often mixed. It's often political. Often there is just a need to have some commitment to have a certain scheme, but often it's also driven by the recognition that the publicly financed scheme that was there, input-based finance scheme that I was referring to earlier, doesn't work, and that money indeed should be following the patient, and that's very hard to do in these rigid PFM systems, as I was explaining before. So recognizing that, a lot of sort of countries tend to then want to bypass that rigid PFM system and set up a separate insurance fund through which they can actually have more flexibility and have money follow the patient. The big problem with these social health insurance schemes, and you see Africa as more light blue, so fewer people are covered as compared to high-income countries. The big problem with these schemes is indeed coverage. You have a very typical situation where governments can use some public money to cover the poor, exempt them from paying premia. They can tax the formal sector on the basis of their wages, and then you have this huge missing middle that sort of is obliged to pay for their insurance premia, but doesn't really do so, and hence uptake is very low. The interesting thing here in relation to academic research is that, and I've worked on this myself before joining the bank, is there are so many papers that show how it's impossible to get high uptake of insurance coverage through asking people to pay premia, and so many different incentives that have been evaluated through RCTs. So the evidence is very compelling. You can't get high uptake if you rely on premium collection, but still we can't. I feel like this evidence doesn't hit home in a policy conversation because we have no alternative. I'm working here now in Morocco. It's the same issue. We're focusing all our efforts on trying to raise premium from the informal sector because there's just no other option, right? That's the other problem sometimes with academic evidence is that yes, we know it will be hard, it will unlikely lead to 100%, but there's no other way. We don't have the fiscal space. There's not enough economic growth. We cannot cough up the budget. So if we want to keep the political momentum around this health insurance scheme and make sure that that it's backed up, then we need to try and keep the people to enroll in the scheme. So this is sort of something I struggle with a lot myself. And a lot of my time I'm working on this issue that I know will unlikely lead to a big result. But this is just where the political demand is and where we have to cater to. Now, a few of these schemes have managed to reach quite decent coverage. This data is not totally up to date, but gives you a sense of some countries. Even, I mean, some Rwanda is not among the richest countries in the entire low middle income world. So quite some countries have managed to get uptake of over, let's say, 50%. But interestingly, you don't see that necessarily correlates with a lower dependency on out-of-pocket payments. So it doesn't seem to be the case necessarily that the more of your population you have enrolled in a certain insurance scheme, the less you will be raising revenue from out-of-pocket payments. And the reason for, okay, and this sort of, wait, now I lost a little bit. Okay, so we see high uptake doesn't necessarily correlate with better financial protection. There's been a very recent paper by Jishnu Das and colleagues that we've had quite a few webinars on already now in all of the bank regions. Have invited him to speak because I think this message very much resonates with what we see in the field. Paper is asking this question: did social health insurance work in low and middle income countries? And the conclusion, I guess, is no, not really. It did lead to some increase in utilization, some financial protection, although you could also say that there's some publication bias there because there's a few schemes that have not been evaluated that we all see in the field have not led to anything. Very low demand, as I said already. Very weak evidence on the impact of health outcomes. We don't really know whether these schemes have increased productivity in the public sector or whether they have led to more engagement with the private sector. But most importantly, we see very little impact because of the weaknesses in the scheme's capacity to manage provider behavior, to actually steer where services are being, where and how many services are being delivered. The price instrument that these schemes have is really not enough. If you look at high income countries, the way providers are regulated, it's a much more comprehensive policy instrument box than you have in these countries where we try to do it only through the reimbursement rates. And then on top of that, the price instrument typically only applies to hospital care because that's the only level where you can actually do reimbursements, where you can have, again, sort of money flowing to the hospital. At the primary care level, you don't have this flexibility, so you tend to sort of pay it through a lump sum subsidy that sort of is linked to input-based financing. So despite these social health insurance schemes getting so much policy attention, they're not really delivering the results that we see. They're not generating more resources necessarily because it seems almost impossible to raise insurance premia. They are very weak in terms of improving efficiency of the health system because of the weak leverage on provider behavior. And therefore have very little impact on outcomes and quality of care. Now, very similar to what I sort of started off with in the first part of the talk is that, again, here, when you look at the literature on this question of social health insurance in low and middle income countries, it's very much focused on the question on the product. Is social health insurance a good idea? Are we addicted to a bad idea? What is the impact of social health insurance on out-of-pocket payments or on utilization? That's sort of typically the papers that you see, the papers I was working on myself as well. But if you work in a country with policymakers, that's not the relevant question, right? That decision has been made. We're not around the table whenever there's a political decision on a social health insurance or not. You are confronted with a certain scheme, and the question then is, how do you support countries in actually, getting a better grip on their providers and having more efficient provider payments within the parameters of their public financial management system. And whether that's in a social health insurance scheme or in a tax-funded scheme, that difference is fairly irrelevant to me. Even, well, as I was explaining before, what is called social health insurance in many countries is in essence a tax-funded scheme, because you can't really raise premia from the informal sector. So I tend to think that in academia, we tend to focus a little bit too much on evaluating the 0-1 impact of a certain instrument, whether it's PBF or DFF or capitation or social health insurance, and not enough on the sort of the real implementation questions that we're struggling with in the field. How do you do this? How do you build capacity of it's actually on my next slide, I think. How do you build capacity of a claims management agency? How do you sort of create that capacity to look in real time at your claims, identify outliers, look at where too much is being spent, where not enough is being spent, and adjust the provider payment mechanisms to that? How do you identify the poor in the most effective way, so that you can exempt them from paying premia, but also in a way that you can adjust over time in case of climate or other economic shocks and people end up being vulnerable? How do you monitor quality? What are ways to get a better sense of quality of care through accreditation? Some countries have these star-based mechanisms through legal frameworks, but how do you get a grip on what's being delivered in those facilities that you contract? And again, all of this in a situation where you have public financial management constraints and health management information system constraints. A big problem often lies in the fact that all these health facilities are not linked to the same health management information system. So I just wanted to conclude then, sort of trying to wrap up a bit what I was talking about. But on the whole, we see that in many low-income and low-middle-income countries, the health sector is underfunded, and it will likely remain so in the near future. So we're very much working in a mindset of creating efficiency gains. There are large volumes of services being consumed at a high cost, often paid for out of pocket and at low quality. So how do we make better use of the resources that are there? A big sort of focus of most of the projects that we would be supporting in the African region is to strategically shift resources to primary care, as that's one of the best buys of the system. But also, I think more generally, as I was saying in the MENA region now, is doing things in the right place. And for example, while for maternity and childcare, it means pushing deliveries to the hospital. For NCD care, it means pushing more screening at the PHC level. So how we create these changes in where things are being delivered through financial incentives and other mechanisms in a context of weak government implementation capacity. I think that's sort of the core of the questions that we struggle with on a daily basis, and that are not always aligned to then the research being done in academia that, as I was saying, is very much focused on evaluating causal impact of an instrument in its entirety. Some examples on the sort of this implementation type of research agenda that we would welcome very much is, how do you get more resources to the front lines in an output-based way? What is feasible? What could be sustainable within a government budget? How do we optimize patient pathways? Again, in a feasible way, given what the system can handle. And how do we steer provider behavior to make sure that these social health insurance schemes get more impact than what they're currently getting? So in some, basically sort of more evidence on the how to strengthen certain systems than on the whether to launch a system versus another.